Hello, and welcome to our webinar, Neglected Tropical Diseases Update, hosted by Wiley and the American Society for Microbiology Press. We're really pleased you're joining us today for this webinar on what is clearly a very important topic, which will cover information around the evolution and progress of the neglected tropical diseases movement from the recently published new edition of Forgotten People, Forgotten Diseases, the Neglected Tropical Diseases and Their Impact on Global Health and Development. I'm Megan Angelini, Managing Developmental Editor of Books at ASM Press, and I was the lead editor for this book. Before I introduce our speaker, I wanted to note that you are all in listen-only mode to cut out any background noise. However, we do invite you to type your questions in the question box in your control panel so the presenter can address them during the Q&A portion of the webinar. This session is being recorded, and in a few days' time, you'll receive a follow-up email with a link to the recording. So without further ado, allow me to introduce our distinguished speaker and author of Forgotten People, Forgotten Diseases, Professor Peter Hotez. Dr. Hotez is Dean of the National School of Tropical Medicine and Professor of Pediatrics and Molecular Virology and Microbiology at Baylor College of Medicine, where he's also the co-director of the Texas Children's Center for Vaccine Development and Texas Children's Hospital Endowed Chair of Tropical Pediatrics, among numerous other appointments. Dr. Hotez is an internationally recognized physician scientist in neglected tropical diseases and vaccine development, and has dedicated his life's work toward championing access to vaccines both globally and in the United States. In 2006, he co-founded the Global Network for Neglected Tropical Diseases to provide access to essential medicines for hundreds of millions of people. He's also the founding editor of PLOS Neglected Tropical Diseases and a former president of the American Society of Tropical Medicine and Hygiene. The floor is yours, Peter.
Thanks so much. So it's great to be talking about something other than COVID-19 for a change. I know many of you have been hearing me the last couple of years speak about COVID, but of course my first love and interest has always been these very interesting sets of chronic and debilitating infections known as the neglected tropical diseases. And I'm happy to partner with the American Society of Microbiology and Wiley for this next edition and update. And oh, now it's not letting me change the slides, so I guess you'll have to do it. So when we talk about the neglected tropical diseases, it really arose out of, in a very interesting way, starting with the Millennium Development Goals in the year 2000, when all global leaders came to United Nations headquarters. At that time, Kofi Annan was Secretary General, and they brought on a set of shared goals for purposes of poverty reduction. And I think one of the big game changers was the fact that for the first time, people were linking poverty to infectious diseases. Today, it seems fairly obvious, but back then, I think that was somewhat revolutionary. And I think, part of the credit goes to people like Professor Jeffrey Sachs at Columbia University, who worked with Gro Brundtland, then Director General of the World Health Organization, who created the Commission for Macroeconomics and Health to finally link those two. And for me, a landmark goal was number 6, Millennium Development Goal number 6, to combat HIV/AIDS, malaria, and other diseases. And that helped launch the President's Emergency Plan for AIDS Relief, PEPFAR, the President's Malaria Initiative out of the US, the Global Fund to fight AIDS, TB, and malaria. And these were all important initiatives. The problem was, for those of us who were working on other diseases, they actually called them the other diseases. And from an advocacy perspective, that was really a disaster. Next slide. And so I like to say that this never happened, right? We didn't, at the early 2000s, you didn't get Tony Blair and Bono and Bill Gates getting up there at the World Economic Forum saying, now we're going to take on other diseases. It just simply didn't happen. And so on the next slide, what we needed to do was in some ways do a rebranding exercise. And I think this was one of the first papers that actually used the term neglected tropical diseases, and it was co-authored by myself and Professor David Molyneux at the Liverpool School of Tropical Medicine and Alan Fennick at Imperial College London, to group together the original list of 13 or 14 conditions, primarily for Africa at the time, that were highly prevalent among the poor, endemic in rural areas of low and middle income countries, generally not emerging infections or pandemic threats, rather ancient afflictions that had been around forever, and they tended to be chronic and disabling conditions that oftentimes were highly stigmatizing and therefore had a particular impact on girls and women especially. And most importantly, at the bottom bullet, not only occurring in the setting of poverty, but actually promoting poverty, actually causing poverty. And I think the one component, though, that was missing is they tended not to be high mortality diseases. And this was the big challenge from an advocacy perspective, competing with those who are talking about HIV, AIDS, and malaria, which were such killer diseases, and getting people to care about chronic and debilitating conditions, even though they may not necessarily be lethal conditions. And we therefore branded them as the neglected tropical diseases. On the next slide. And since then, the term has stuck, and now, of course, we have a World Health Organization Department of Neglected Tropical Diseases, and they've now expanded that list to 20 conditions, and I'll show you the list in a bit. But the major theme still holds: chronic debilitating conditions, and we've progressively updated this concept of neglected tropical diseases through this book, Forgotten People, Forgotten Diseases, that very much does a deep dive into why we should care about these conditions and how we're managing them and how we're hopefully working to control and one day eliminate them. Next slide, please. And then we even launched a new open access journal, the Public Library of Science for Neglected Tropical Diseases. So there were a lot of elements around the book and the journal to kind of help foster the creation of this new ecosystem. Next slide. So here's the current enumeration of the prevalence or incidence of these neglected tropical diseases. I say incidence because a few of them have gone off script in terms of they're not necessarily chronic and debilitating infections, but enough of us have thought they should still be included. And so for some of them, like dengue, we give actually incidence numbers or Zika, we give incidence numbers rather than prevalence numbers. And this is the latest enumeration from the Institute for Health Metrics, the Global Burden of Disease study that measured them right before the pandemic. And I don't know that the numbers per se are so important for you to remember, other than the fact that when we look at the world's poorest people, the 750 million people who live below the World Bank poverty figure of $1.90 a day, essentially everyone is affected by at least one of these neglected tropical diseases, and more often than not, more than one. And these are the conditions that not only are causing deterioration in health and interfering with child growth and development and the health of girls and women, but actually trapping populations in poverty. And I think this was one of the ways that we were able to impress upon the global policymakers why they were so important. Next slide, please. So a couple of examples. This is a slide I believe David Millennium provided for me. It shows an individual affected by elephantiasis, the chronic, most debilitating form of lymphatic filariasis, which is one of the most common neglected tropical diseases. And he says it's quite a problem for me when I have to stand at work for long periods. And this emphasizes the chronic and debilitating and disfiguring nature of the condition, but also the fact that he's too sick to go to work and provide for his family, hence the poverty promoting aspect. Next slide. And this is one which a number of us are working hard to raise global awareness about. So schistosomiasis is a parasitic worm infection of more than 100 million people, including 40 million girls and women. We estimate, this is from a New England Journal paper we wrote, that causes a condition known as female genital schistosomiasis. And I think of it as one of the most common gynecologic conditions on the African continent, and it's caused by the spine-shaped eggs of the parasite that lives in the blood vessels, get into the cervix, the bladder, the uterus, and lower urinary and lower not only urinary tract but also genital tract, and it causes pain and bleeding and social stigma. It's been linked to depression, marital discord, and it's particularly common among adolescent girls and women, young women. And so we've heard reports now of community health workers often accusing these girls and women of sexual promiscuity when in fact they are standing in contaminated water with the larval stages of these schistosome parasites that penetrate through the skin. And this is not a rare condition, 40 million girls and women, and now it's been linked by studies at the University of Oslo and Weill Cornell Medical College to a 2 or 3 or 4-fold increase in acquiring HIV/AIDS. So that's the other piece to these neglected tropical diseases, is they increase susceptibility to co-infections such as malaria or tuberculosis or HIV/AIDS. Next slide, please. And as I mentioned, they're not typically emerging infections. These are ancient conditions. In fact, you could read the history of these in ancient texts such as the Bible or the Talmud or the Vedas or the writings of Hippocrates, or Egyptian papyrus has descriptions of them, and these are some examples. So they're biblical diseases. They're the diseases of all of the ancient texts, and they've impaired the quality of life and the health of the humankind for thousands and thousands of years. And I think that's another very important aspect of these conditions. Next slide. So what do you do about them? Well, one of the rationales for helping launch this neglected tropical disease ecosystem in the early 2000s was there had been a lot of exciting work done in the 2 decades beforehand about this concept of mass drug administration. That is going into an endemic area and administering treatments on an annual basis or sometimes twice annual basis without necessarily going in and trying to establish a diagnostic diagnostic test in each individual. In other words, once you knew the community prevalence reached a certain point, the thinking was almost everybody, if they're not infected now, would become infected. And the idea is by not having to do the diagnosis at the time, bringing in trained microscopists, it greatly lowered the cost and could be administered inexpensively. And in some cases, individuals like Don Bundy and Lorenzo Savioli showed it could be this could be done in the schools. Alan Fennick at the Schistosomiasis Control Initiative had showed the same thing, or the Lymphatic Filariasis Control Program, and doing this at the adult level. And so the point is, we had a group of medicines that could be provided at low cost and either use community health workers or school teachers or others that didn't need to bring in necessarily trained health professionals in order to administer. And all those things made this approach extremely inexpensive. Next slide, please. So this shows some of the pre-2000 results or early 2000 results of mass treatment. So here on the top left, showing ivermectin given annually for the treatment for lymphatic filariasis, or Zithromax for the treatment of trachoma, or diethylcarbamazine citrate for lymphatic filariasis. And the left, praziquantel in Egypt for schistosomiasis on the right. And many of these medicines had been developed by multinational pharmaceutical companies for other purposes, but they could be repurposed at low cost for a neglected tropical disease. The best example is Zithromax on the upper right, developed by Pfizer. It's used for upper respiratory infections in the United States, but it could also be repurposed for mass treatment of trachoma and actually at some point lowered the transmission of the illness as well. And that part about lowering transmission, it didn't work for every neglected tropical disease, but did for things like lymphatic filariasis or onchocerciasis or trachoma, helped give it another alternative name other than MDA, or mass drug administration, calling it preventive chemotherapy or preventive treatments or preventive therapy. And this started gaining a lot of momentum in the early 2000s. On the next slide. And then our group started noticing the enormous overlap of these conditions. So this is from an early paper that we wrote in Scientific American, looking at the overlap of 7 or 8 of the most common neglected tropical diseases that could be targeted for preventive chemotherapy: Ascariasis, Trichuriasis, hookworm, Schistosomiasis, etc. And of course, there's overlap, and that meant the possibility that maybe we could, there's economy of scale by combining these interventions in a package of medicines, which we originally called the Rapid Impact Package, that could be scaled rapidly. And the next slide, please. And so here was some of the medicines used in the Rapid Impact Package, and in time, the multinational pharmaceutical companies began donating it. So GlaxoSmithKline was donating albendazole, Johnson & Johnson mebendazole, the Japanese company Eisai diethylcarbamazine, Merck & Company ivermectin, the German Merck KGaA, providing praziquantel, Pfizer providing Zithromax. And we could target, some of the most common neglected tropical diseases, and notice that there were some collateral benefits as well. And if you click again, I think it will bring up another something else on this slide. Go ahead. And the point is, because the medicines were being donated, and you did not necessarily need a trained healthcare professional to deliver it. It was costed at about 50 cents per person per year. And if you go now to the next slide, I think the exciting thing was, as momentum was building for global health because of Millennium Development Goal number 6 for AIDS, malaria, and TB, we made the case, look, for an added 50 cents a person per year, it's, when you round it off, it's practically free. And that's where this concept of the Rapid Impact Package went. And what we then wound up doing was fairly heavy lobbying with the United States Congress and as well as the UK Parliament to provide support for this. And the other benefit that we had in the early 2000s was things were not as polarized as they are today. Democrats actually spoke to Republicans, and Republicans spoke to Democrats. So, I could meet with Senator Sam Brownback at that time. Before he was governor of Kansas, he was senator for Kansas, go to his prayer breakfast and then walk across the hall to Senator Leahy from Vermont and get them to work together to appropriate legislation. I'm not so sure that could happen again today. So that was the other fortuitous aspect. Next slide. And there's the three of us, sometimes known as the three Musketeers, with my good friends Alan Fennick and David Molyneux, to begin, going to UK Parliament, going to the German Reichstag, going to some of the European capitals to convince policymakers that this was worth supporting. And the next slide. And here's where we're at now in terms of on the US side with USAID, which established the Neglected Tropical Disease Program. And it started modestly with $15 million in 2006. And now that may not sound like a lot of money, but in today's dollars, but at that time, remember, if we're talking pennies to treat people, we're talking still tens of millions of individuals that we can get treated. Now we're up to about $100 million annually. We've plateaued. I'd like to see this continue to go up. And the way this now works is the USAID NTD program partners with contractors and non-governmental organizations like FHI 360 or RTI International and others, and now getting these treatments delivered at an extraordinary pace to the point where we can actually talk about the elimination, because it's interrupting transmission, of lymphatic filariasis. That's what LF means, onchocerciasis, trachoma, and ascariasis, and doing pretty well with reducing conditions such as hookworm and trichuriasis and schistosomiasis, although we are seeing quite a bit of rebound post-treatment reinfections, but still, towards that humanitarian goal of making certain kids, especially in adolescence, are worm-free as much as the time possible in order to prevent them from the growth delays, things like female genital schistosomiasis and all of the other inflammatory and anemia effects of these parasitic worms. Next slide. And now the advocacy has stepped up, in part through support of the Bill and Melinda Gates Foundation, the organization based in London, Uniting to Combat Neglected Tropical Diseases, is working to help work with the World Health Organization Department of Neglected Tropical Diseases, headed by Mwala Malachela from Tanzania, work with the various non-governmental partners and the ministries of health for this treatment. And I think one of the exciting things about the NTD space is that it's very much empowering for the ministries of health in disease endemic countries in Africa and elsewhere. So, there's a lot of buzz now. The new buzzword in global health is decolonized, that it shouldn't be North America and Europe dictating how to do this. And in fact, I think in many ways, neglected tropical disease control under Mwala Malachela's leadership and the African Regional Office of WHO and ESPIN and others have been able to really empower both the ministries and the people themselves for these treatments. And I think in terms of sustainability, that's extremely important. Next slide. This is an article that David Allen and I wrote, finding also some interesting unexpected collateral benefits from when we first wrote those papers on the integrated package. And for instance, finding that the Zithromax component not only was beneficial for trachoma, but also yaws. So we can even talk about the elimination of yaws, or the ivermectin component for scabies. And now there's a scabies alliance through mass treatment with ivermectin. The bottom middle panel to me is one of the most fascinating ones that I don't think we quite understand. And this came out of Tom Lietman and his colleagues' work at UCSF, and Dr. Keegan, where they show that that when you go in with this drug package or even the Zithromax component, you see an unexpected reduction in child mortality, which is, I don't think that's something we necessarily anticipated, since the neglected tropical diseases are, as I've been stating, are not really killer diseases. So what's the basis of that? And through Gates Foundation support, we've seen unexpected, we've seen this reproduced, maybe not to the extent when it was first published in the early 2000s in Ethiopia, but still reproducible in other African countries. And to me, this is still a bit of a medical mystery, whether it's related to reducing pneumococcal carriage or whether it's related to reducing diarrheal pathogen carriage. It's still something that's extremely important to study. Next slide. And now we have our own World Neglected Tropical Disease Day, which is January 30th, and I look forward to celebrating our third one in a few months. Next slide. Now, there are a number of side stories around neglected tropical diseases, which I get into in the book. And one of them, which actually is its own separate book, is this concept that when we talk about neglected tropical diseases in that version 1.0 framing, it was very much around fragile nation states and areas of extreme poverty in Africa, Southeast Asia, and Latin America. And that still holds. But the other interesting piece of this is the unexpected disease burden in the group of 20 nations, the G20 countries, as well as Nigeria, which is not a G20 country, but it has an overall economy larger than the bottom 3 or 4 G20 countries. And when you add up the disease burden, these wealthy nations account for, on the right, most of the world's worm infections, and that's what Helminth's means, visceral leishmaniasis or tuberculosis or dengue or Chagas disease or leprosy. And it's something I've given a name to, I call it blue marble health, because it's not, in the traditional norm of poor versus wealthy countries, but rather the poor living among the wealthy that are accounting for an unexpected burden of disease. So for instance, Brazil, Mexico, and Argentina, which are the wealthiest countries in Latin America, have these pockets of extreme poverty and neglected tropical diseases. And this has a lot of policy implications, because in many cases, it's not necessarily a resource issue. It's a matter of getting global leaders of the G20 nations to commit to their own vulnerable populations. And many are surprised when they see that I've carved out a piece of the southern United States there as an impoverished area. Next slide. And this is one of the reasons why we created our School of Tropical Medicine here in the South, in Houston, Texas, part of the Texas Medical Center. So our scientists like Rogelio Mejia have been working with Catherine Coleman Flowers, an environmental justice activist, where she's been identifying areas of profound poverty in places like rural Alabama. And we've teamed up with her, and Rogelio's and colleagues have shown that there's still hookworm in the southern United States. So there is this hidden burden of neglected tropical diseases among the poor in the US. And the next slide, please. And indeed, back in 2017, Philip Alston, who was designated the UN Special Rapporteur on Extreme Poverty and Human Rights, came to the US in 2017 to point out that we have 18 million Americans that live in extreme poverty and half the US poverty level, and 5 million Americans living on less than $2 a day, the benchmark for global poverty. And it's not something that's been easy to talk about. In fact, with the successes that we had on neglected tropical diseases, raising awareness in the WHO department in places like Africa, Asia, and Latin America, we thought, hey, when we start finding these diseases in the US and highlighting them, then this will really take off. And quite the opposite has happened. This has been one of my hardest advocacy fights I've faced, right up there with, combating anti-vaccine aggression. This has been tough as well, getting people to care about diseases of the poor in the US. And finally, we've gotten some individuals like Senator Cory Booker of New Jersey, and Congressman Chris Smith of New Jersey also, and Hank Johnston of in the Atlanta area and Georgia, and Sheila Jackson Lee here in Houston, to care about these, to emphasize, put special emphasis on them, and to start doing more active surveillance. Next slide. So for instance, here in Texas, where we have some of the worst poverty in America. So on the bottom left is along the Mexico border, the Colonias, where you find discarded tires breeding Aedes aegypti mosquitoes, and we're finding in Chagas disease transmission that was worked on by Christy Murray and her colleagues here in the School of Tropical Medicine, and Melissa Nolan, now in the University of South Carolina. But on the top there, these are pictures just a few miles from the medical center where I'm seated, in the 5th Ward of Houston. Dilapidated housing, discarded tires, again breeding Aedes aegypti mosquitoes, Aedes albopictus mosquitoes. And this has been a very tough sell to get people to care about this. And now we've got some disease legislation that's been that the Texas legislature has passed, and there are several groups now looking at this in more detail here in Texas. And the next slide. And one of the more interesting ones that we're working to raise awareness on are this parasitic worm infection known as Toxicoriasis, and it's transmitted by stray dogs and cats living in poor neighborhoods, which are throughout the South, but also even in the New York area. So they've recently done a study to find high rates of collecting Toxicora eggs in the Bronx, for instance, the poor areas of the Bronx, where this disease is probably endemic, and it's now been linked to developmental delays. And so one of the questions that we've loved to ask, but it's been very tough to get support for, is if this is widespread among the poor, what's the impact on socioeconomically disadvantaged kids who are not doing as well in school? We always talk about this due to deprivation of education, lack of access, and of course that's a factor. But I think this is also an environmental cause. These parasite eggs that give rise to the larvae that migrate in the brain to cause this, what's probably the most common parasitic worm infection in the United States. Next slide, please. Next slide. And the other aspect of this is the research and development agenda. So in addition to doing coronavirus vaccines for the last few decades, now based at Texas Children's Hospital, in the Feigen Center of Texas Children's Hospital, which is a research arm of our National School of Tropical Medicine, together with my science partner for the last 20 years, Mary Elena Batazzi, we've been exploring how to begin developing vaccines for these conditions, because especially for diseases like the intestinal nematodes and schistosomiasis, where you get reinfection, can we, after treatment, vaccinate, similar to how the malaria vaccine would be used as the new malaria vaccine, not as a replacement technology, but as a companion technology, along with bed nets and anti-malarial drugs. And this has been a long-standing quest, and we are making progress, although much slower than we'd like, because of the constraints of resources, especially as you're going into phase 3 trials and then pivotal studies in industrial scale manufacturing. Next slide. And we actually call them the anti-poverty vaccines, because they're vaccines, and of course that would have an impact not only on illness, but on helping lifting people out of poverty. And it's not a term that's really taken hold. It's something I feel fairly passionate about. I've written about it a few times, but it's like the blue marble health concept. I keep putting it out there. It never quite gains critical mass, but I still keep trying. Next slide. And so this is two of our signature programs, vaccines for hookworm and schistosomiasis. And again, you can see just by the map that this is not easy to encourage the multinational pharmaceutical companies to take these on, because they are for the poorest of the poor. They're not even in the middle class in African and Latin American and Southeast Asian countries. And we can go pretty rapidly through these slides, I think, so we can leave enough time for questions. Next slide. So our schistosomiasis vaccine was discovered, the signature antigen, through work by Jeff Bethany and Alex Lucas. Jeff's at George Washington University and Alex is at James Cook University. They took a microarray approach looking at surface antigens of the schistosome parasite and then overlaying it with serum from putatively resistant patients in order to identify promising surface antigens of the parasite. This was kind of immunomics version 1.0, but it was very powerful. Next slide, please. And here's one of our lead antigens, this SMTSP2 antigen on the surface, which was highly immunogenic. And when you induce an immune response to it, it affects the biogenesis of the surface and makes it more vulnerable to immunological attack. So it's a very interesting scientific mechanism. Next slide. And Alex and his colleagues are able to do things like RNAi for schistosomes and show how it affects the biogenesis of the tegumen. And now we've cloned and expressed this recombinant protein in yeast, and it's now being scaled up for production and going through phase 1, phase 2, phase 3, now hopefully phase 3, eventually clinical testing. Next slide. And this is the phase 1 study that was supported by the NIH. Our recombinant protein vaccines are usually on alum formulations, but we almost always find we need another TLR agonist, toll-like receptor agonist, to stimulate effective protective immunity. And this is always a problem that we have with our parasite vaccines, is access to adjuvants. So in this case, we've been partnering with IDRI, the Infectious Disease Research Institute, that's made available an aqueous formulation of glucopyranacil lipid A that's almost similar to MPL, monophospholipid A. Next slide. And our hookworm vaccine, again, here's the distribution of our hookworm vaccine, and you get the idea that it's pretty mostly affecting the world's poorest people, and so that conventional sustainable finance mechanisms for vaccines don't really apply for something like a hookworm vaccine. Next slide, please. And in this case, the mechanism of action of our vaccine for hookworm is also very innovative, but not a surface antigen. What I'm showing you is a cartoon of the cross-section of the gut of the worm that's studded with proteolytic enzymes involved in hemoglobin digestion. And what we do is we cloned and express some of these hemoglobin digesting enzymes or heme detoxifying enzymes like glutathione S-transferase, which is specially modified for binding up heme, and find that if we induce antibody, the worm ingests the antibody, and then it destroys the gut of the hookworm, a very innovative mechanism for an animal, basically, which is what a hookworm is. And next slide. In this case, our vaccine effort for now is being led by a consortium of European and African institutions in collaboration with the Amsterdam Institute of Global Health and Development, Dutch universities, German universities, including University in Tübingen, and the Lambaréné Research Center in Gabon. We've just published now this co-administered bivalent vaccine of 2 enzymes that in a phase 1 trial. And again, we're getting good immune responses there as well. Next slide. And next slide after that. We have also been trying to work with LEK Consulting to help us cost out what it's going to get us to the finish line in terms of licensure. And it's not billions of dollars, but it's not cheap either. So, getting into that tens of millions of dollar range to get all the way to phase 3 trials, this is one of our big issues. So I often visited by a lot of young people who want to go into global health, and they think I'm going to tell them to get an MD or PhD in tropical diseases. And I say, look, we also need people with legal training and MBA training to help us figure out this sustainable finance model for this. And I think this is almost as important as the scientific hurdles. Next slide. And this is our Chagas disease vaccine program. It's led by Catherine Jones. And here, this will be more of a therapeutic vaccine to prevent the blue at the bottom there, which is a Mallory trichome strain of collagen. So once the parasite's in the heart, it induces fibrosis and inflammation. And this immunotherapy, which we're doing with support of the Carlos Slim Foundation and others, including the Clayburgh Foundation, is being now helpful to show how we can reduce the inflammation and fibrosis of the heart, because once the disease progresses to a certain point, then the anti-parasitic drug benznidazole is not as effective. So the Drugs for Neglected Disease Initiative, for instance, is very interested in identifying better drug candidates. And in parallel, we're working to see if we can complement the anti-parasitic drug therapy with that immunotherapy. Next slide. So that's it. I guess in order to have more time for questions, I was going to talk a little bit about our work on COVID and our COVID vaccine, but I think I'll save that for another day. And because I do want to be able to leave some time for audience participation and questions. And apologies that we're a little bit of a late start because of some technical issues with the webinar, but I'm glad we were able to get most of that in and leave some time for questions. So let me stop there and we can open it up.
Thank you so much, Peter. We've had a lot of great questions come in through our question chat. So I'm just going to go ahead and read those to you. So the first one is, you mentioned that mass drug administration, for example, for schistosomiasis, has not yet been able to eliminate disease as rebound infections occur. Why do these rebound infections occur? And does this mean that elimination with MDA solely is not possible? Are other additional interventions needed to break the transmission cycle?
Right. So I think, in the case of schistosomiasis or hookworm or trichuris, the environmental stages are just so ubiquitous that and so pervasive that it's just hard to keep up with that pressure with mass drug administration alone. Now, for full disclosure, there's not consensus in the scientific community about that. So if you were to talk to my good friend and colleague Alan Fennick, he would still say that yes, we think it's still possible to eliminate schistosomiasis even in areas of high transmission with drug therapy alone. I think we're going to need additional control tools like a vaccine. But now there's a very interesting project going on the intestinal worms, also funded by the Gates, and it's called the DWORM 3 project, run out of London and Seattle by Judd Walson. And what they're doing is they're actually trying to see if there's situations where they can really max out drug therapy, mass treatment, and show it, at least at a pilot scale, that you can affect elimination through proof of concept for that. We have been able to see this happen in areas of middle income countries that you can affect elimination. The issue there, though, is the fact that it's not the only thing going on. What's happening is you're getting very aggressive economic development happening. And that has the effect of, through urbanization and taking people away from agrarian pursuits into factories and improving the quality of sanitation. All of those things together are when mass treatment tends to start eliminating intestinal worm infections like hookworm. So for example, you look in what happened in South Korea after World War II, it wasn't only mass treatment. You had very aggressive economic improvement. Same with Japan after World War II. Same as you're seeing in Eastern China over the last 20 years after Deng Xiaoping. You're seeing very aggressive economic development, or in the southern United States. But without that economic improvement in sanitation, or what we call WASH, water and sanitation hygiene, I don't think mass treatment alone is really going to have that substantial an impact on the intestinal worms in terms of elimination. I mean, and schistosomiasis, we do it because it's the humanitarian thing to do. I mean, we cannot let girls and women unnecessarily suffer from female genital schistosomiasis or hookworm infection in pregnancy, but where it causes severe anemia and high morbidity, mortality to pregnant women. But for a longer term impact, I think we're going to need additional control tools like vaccines. But with full disclosure, not complete consensus in the community on that.
Thanks. You actually touched on a number of other questions that came up in that answer as well. So moving on to the next one, how do you see climate change impacting the NTDs now and into the future?
That's a great question. In fact, I've written one paper on this for PLOS neglected tropical diseases. And what's really interesting when you look at climate change, it's not as straightforward as you think. So for instance, clearly warming temperatures, Simon Hayes group at the Institute for Health Metrics has shown that it's going to expand the suitability of the Gulf Coast, for instance, for disease transmitting mosquitoes like chikungunya and Zika and dengue. But sometimes it has paradoxical effects. So for instance, with schistosomiasis, the warming temperatures, sometimes it's so hot and dry to go along with it that it's actually declining the fecundity and the survivability of snails that transmit schistosomiasis actually going down. But there's sometimes you can see there's a commensurate rise in parts of Africa at higher elevations that formerly did not support the transmission of schistosomiasis because of cooling temperatures, but now it does. So it's not so much that everything goes up, some things go down and some other things go up. Simon Brooker years ago showed that, for instance, hookworm larvae are surprisingly thermotolerant. So as you get hotter and hotter temperatures in places like Chad and in the Sahel, hookworm becomes the dominant helminth in that part of the country. So what I have found with climate change is there are important effects, no question about it, but it's hard to predict. You don't know till you know. And then there's some instances where we think it's climate change, but we can't say for certain. So for instance, now we have the emergence of a form of schistosomiasis in Corsica off the coast of France. Is that due to global warming? Potentially, but there are other things going on like human migrations and shifts in the economy and poverty. So I think part of one of the things that I have found is climate change seldom works in isolation. It's working in concert with other social determinants such as urbanization, conflict, and many of these other things.
All right, the next question we have here is, many of the recognized NTDs are of parasitic origin. What's your take on fungal infections other than mycetoma being classified as NTDs?
Yeah, so this is always an interesting question of who gets invited to Studio 54 and who doesn't, who gets to belong to the club. And one of the things when we started PLOS neglected tropical diseases in 2006, 2007 is we had that list from the WHO, and then people would submit the paper of something like strongyloidiasis, the most neglected tropical disease, because it was even neglected by the neglected tropical disease people. So for For PLOS, we wound up enlarging the tent quite a bit. I think it's up to around 40 conditions now. It's Shed and Kamhawi and Paul Brindley are the editors in chief, and this is a constant discussion and fine tuning of what goes on the list, what doesn't, because you don't want to be so restrictive that you actually jeopardize populations living in poverty, because they're not the diseases that are affecting them are not being prioritized. On the other hand, if you make it too broad, and then it just becomes a laundry list, and then everything becomes a neglected tropical diseases. So there's that sort of balance. So mycetoma and other related chronic fungal infections recently got added now for that list of 20. I think it made a lot of sense, but sometimes there's give and take and understanding what constitutes now an NTD, what doesn't.
Thanks. There were a lot of questions in the chat asking about other specific pathogens as well. So the next question is, what role, if any, do you see for diagnostics in NTDs?
Well, just like the drugs and vaccines that have not benefited from all of the changes in the biomedical revolution that started in the 70s and 80s, the same is true of diagnostics. I mean, one of the real gaps is point of care diagnostics. Let me give you an example. So Toxicora. I mean, if you suspect someone has developmental delays from Toxicora, what do? Well, it's not like you have a lab slip from Quest Diagnostics with a little box that says Toxicora, right? It's a specialty test that has to be arranged beforehand with the Centers for Disease Control, or maybe our labs, National School of Tropical Medicine. So it becomes the cumbersome diagnostic testing itself becomes a barrier to access, and so we need simple point of care diagnostics like a pregnancy test or like a home COVID test, and I think those would be game changing. So now there's a very important product development partnership for neglected disease diagnostics based in Geneva, known as FIND, F-I-N-D, and I think we need more of that. And PATH is doing diagnostics as well, but also very much orphaned, and for any neglected tropical disease, we have the opportunity for improved diagnostics. So one of the things that we're doing now is looking at PCR-based studies, because the old way of doing fecal exams was to have a trained microscopist to find the eggs, but Rogelio Mejia and Tom Nutman and others have been looking at how to take a small stool sample and then use a multiplex PCR, where you can not only get intestinal worms, but you can get the intestinal protozoa, which are often underdiagnosed as well, like Cryptosporidium or Giardia. So also very important.
And sort of tied to that, and there were a lot of questions about this. Do you think, what are your thoughts on the distribution of these drugs without diagnosis and its correlation with emergence of drug resistance?
Yeah, so drug resistance is something that is understudied, and there is an initiative for that purpose, and I talk about it in the book. And I remember trying to get support for looking at drug resistance, and this went through an NIH study section. They said, and they declined it for funding because they said, well, you didn't show there's evidence of drug resistance. I said, I know we didn't show there's evidence of drug resistance. We're asking for support to show evidence of drug resistance. And so you get into this chicken and egg phenomena where the donors don't want to support it unless you've shown it, but you need the funding to actually show it. And that gets very frustrating. And so I think we need more of those drug studies, because let's face it, this is being done on an enormous scale now. And we have documented a few instances of drug resistance with some of the NTD pathogens, and we need to learn our lessons. I mean, we said with great bravado in the 60s that we're going to eliminate malaria with chloroquine and DDT, and then DDT resistance among mosquitoes set in, and chloroquine resistant malaria set in. So I think so this kind of operational research going alongside it is so critically important, but it's not easy to persuade the donor community or even governments, because you go to the U.S. Congress and say we also need to look at drug resistance, And you said, well, but why do we have to do that? Let's just treat everybody. And it adds to the cost, but it's so critically important.
Well, thank you so much, Peter. We're getting close to time. So I want to thank Dr. Hotez for all of the excellent information that was presented, and the audience for all the thoughtful questions. Sorry we couldn't get to all of them in the time here. And thank you for taking the time to join us today. Just as a reminder, the recording of the presentation will be emailed to you within a few days. And with that, we're going to close out our webinar.